Namaskar. Hello friends, I am Dr. Jay Prakash Shah and I am practicing fetal medicine at CTM Charasna, Ahmedabad in name of Rajni Hospital and at St. Xavier's College Corner, Navrangpura, Ahmedabad in name of Rajni Fetal Medicine Center along with Dr. Pasha. Here I am presenting a case of tetralogy of fellow with pulmonary stenosis. As we know, tetralogy of fellow are of three varieties: tetralogy of fellow pulmonary stenosis, tetralogy of fellow pulmonary atresia, and tetralogy of fellow absent pulmonary valve. Here I am going to present a case and details of tetralogy of fellow pulmonary stenosis. Tetralogy of fellow was first described by Etienne Louis Arthur Fellow in late 19th century. Initially it was termed as blue baby as well. In the left upper corner you are seeing a normal anatomy of the heart. While what happens in a tetralogy of fellow, as the name apply or suggests, there are four defects that you are identifying. The first defect is a ventricular septum which is defective. Normally, the interventricular septum is continuous with anterior wall of aorta, but here when there is a ventricular septal defect, the interventricular septum overrides the aorta and it is displaced over aorta and it overrides the aorta by less than 50%. The third finding is small pulmonary, leading to the pulmonary stenosis and or pulmonary atresia in a severe cases. And the fourth finding is ventricular hypertrophy of the right ventricle. Normally this finding is not identified in tetralogy of fellow cases in utero. As we are doing, you have to follow the guidelines for the fetal echocardiography. So your echocardiography should start with the abdominal circumference. Here there is a spine, stomach and portal which is in a clockwise rotation, and the patient was having a cephalic presentation, so that indicates that the stomach is lying on the left side. And when you move to the 4-chamber view, you will identify the heart also deviated to the same side, then confirms the situs solitus. Normally the axis is normal in cases of tetralogy of fellow, but there can be axis deviation in some cases if it is associated with the complexity or the inequality of the chambers, then one can identify the axis deviation as well. Usually the aorta is situated little to the left, but in few cases of tetralogy of fellow, one can identify the aorta situated just in the midline or little bit to the right side of the spine. This is 4-chamber view, and as you can see, the 4-chamber view appear normal. This is left outflow tract. You can identify ventricular septal defect. You are seeing the ventricular septum which is overriding the aorta, and you can see the flow to the aorta from both the side, from both the ventricles. The same you are confirming in color as well. When you measure aorta, it is usually little bit enlarged. Here again you are confirming the finding of ventricular septal defect, overriding of aorta, and the flow from both the ventricles to aorta. When you move to the right outflow tract, you will identify pulmonary which is smaller and as compared to the aorta. Normally, the pulmonary is the largest vessel in three vessel, and when you come to three vessel view, in three vessel view you notice small pulmonary, large aorta, and normal superior vena cava. Notice that anterior border of pulmonary, superior vena cava, and aorta are not exactly in the same line as you are noticing in a normal three vessel view. At the same time, notice the presence of thymus gland anterior to the three vessel view between sternum and all the three vessels. When the thymus is hypoplastic or absent, you have to think about the possibility of the DiGeorge syndrome as well. And this is a live clip of tetralogy of Fallot. Notice the one ventricular septal defect overriding of aorta and small pulmonary in right outflow tract as well as in a three vessel view. And, same four chamber view with 2D as well as 2D with color, and you are noticing everything live in this clip. And when you record HD stick, you can identify ventricular septal defect and flow from both the ventricle into the aorta, as well as notice the small pulmonary vessel. And you can use Silauti flow also, make the transferent flow, and you can confirm the presence of ventricular septal defect and flow from both ventricle into aorta and small pulmonary vessels. Thank you, friends. If you want to review a video on tetralogy of Fallot absent pulmonary valve, you can search in the same channel, that is Radni Fetal Medicine Center and Fetal Heart video playlist. If you like the video, you can subscribe to it, and please don't forget to press the bell so that you can get the notification whenever a new video is uploaded. Thank you.